Yeah.
It just means I've got to look.
It's just that one that's funny.
That's fine. Oh, now that one's not right.
I'm doing it at this stage.
It's working on the webinar, but not on here. Is that a major problem? Is we just
Can we go mirror show?
Let's go. Yeah.
And then, what's that like for you?
Good. Let's go.
Oh. Now, just to, is that right for me to? Sorry about the delay, everyone. So starting again, so my name is Courtney and I'm the PhD candidate for the tertiary care stream. The article I'll be presenting today is titled Guidelines for the Treatment of Pneumonia and Urinary Tract Infections, Evaluation of Methodological Quality using the Appraisal of Guidelines, Research and Evaluation to Instrument. I thought I'd start off my presentation with a quote from the authors of this article. Reliance on evidence-based medicine requires high methodological standards from guideline developers. The focus on methodology will be evident in my presentation today. I'll look at the importance of guideline development and its ability to link evidence-based medicine with current practice. So why did I choose this article? Because there's an increasing focus on the development. Oh, it's not working. Sorry, everyone, just a moment.
Is that just your iPad?
I can't tell.
Can we text someone? Just ask me.
Slides on it.
Yeah, Kirsty's saying slide over the bench.
It's gone. Is it?
It's not working.
Maybe. This is a go-to meeting, actually, not.
I have no idea.
I mean, it's definitely go-to. It's working. Is it? It's working.
No, but the slides aren't advancing.
The slide, maybe just try again, advance the slide of the presentation page. I mean, just maybe just minimise that. What can you see there? Is that advancing?
I've got the open slide. Yeah, it's not going off in there.
I don't know. I mean, this is a go-to, isn't it? It's not going to be that.
No idea.
Would you like to maybe get a vet to go first?
I don't think it'll matter.
Tell everyone, maybe just chat and just say, well, hi everyone, we think this might be a go-to problem, not our presentation problem. We can certainly record the presentation and post it to you. We just need to work out how we're going to deal with the vets talk about.
Looks like it's working now.
Is it? That changed? No. Let's adjust the windows. It's changing. Oh, good. It's working. It's working.
Let me start from
No, just go back to here now.
Yep. Okay. So I'll just go back to the slide before because it was stuck on the initial slide. So the quote that I'm talking about is this one here. So reliance on evidence-based medicine requires high methodological standards from guideline developers. So I'll be focusing on methodology throughout my presentation today. So why did I choose this topic? There's an increasing focus on the development and implementation of guidelines across healthcare systems, and it can be quite a complex process. But it's important to note that practicing evidence-based medicine is not necessarily synonymous with being concordant to a clinical practice guideline. And a reason for that is that there's a broad range of quality across clinical practice guidelines, and according to current literature, this is predominantly low. The benefit of clinical practice guidelines, though, it enables a combination of low and high quality evidence to be mixed together. By having expert consensus reviews appraise this lower quality evidence in relation to higher quality studies, you get a more rounded view of the current literature, and then it could possibly make it more applicable in a wider range of contexts. However, again, this process can be quite complex, and if it's not done in a systematic approach, gaps start to form, and then that then impacts upon how a guideline can be applied. So looking at the uptake of guidelines and evidence-based practice, they can be influenced by a number of facilitators and barriers. Identifying these facilitators and barriers is critical when trying to adopt evidence-based practice. Specifically for infectious disease guidelines, the authors of this article found that antimicrobial resistance, ecological impact of treatment recommendations, and paucity of evidence in critically ill patients were of extra concern, particularly the evidence in critically ill patients, as they are our target users for guidelines. So how do we then identify these barriers and facilitators? Through the use of guideline appraisal instruments. The current literature highlights an increasing utilisation of these instruments. They provide a structured and systematic approach to critiquing guidelines and will help identify these barriers and facilitators. The most current systematic review assessed 40 instruments and found that the most comprehensive English instrument to date is the Appraisal of Guidelines, Research and Evaluation, also known as AGREE. And there's the most recent version, which is the AGREE 2, and that was the one that was found to be the optimal instrument in that review. So the AGREE 2 instrument is internationally known and validated. It's been utilised across a range of healthcare clinical guidelines, including depression, osteoporosis, diabetic retinopathy, falls prevention, and then the article that I'm going to talk about today, which includes pneumonia and urinary tract infections. The instrument consists of 23 items across 6 domains. So that includes scope and purpose, stakeholder involvement, rigour of development, clarity of presentation, applicability, and editorial independence. On this slide here, this is an excerpt from the AGREE 2 manual, just highlighting what it actually looks like. So this is for domain 1, scope and purpose, item 1. The appraiser can review the guideline according to the description given in the manual and then quantifies this on a 7-point Likert scale, 1 for strongly disagree and 1 for strongly agree. And then there's additional room for comments. The manual also provides suggestions as to where they can find item information and guidance as to how they rate this information. From this, we then calculate a domain score. This is then done as a scaled total percentage of the maximum possible score for that domain. So the example I've got down in the bottom right-hand corner is, say we've got a score of 3, the minimum score is 1, and maximum score is 7, and that then generates a percentage of 33%. Now, this is just for one item of the domain. So domains consist of multiple items, and that's just for one appraiser. So then for more appraisers and more items, that maximum and minimum score will be bigger. But at the end of the day, it's still all aggregated to that percentage. So the article predominantly uses the agreed-to instrument as its key form of methodology. It was published in the Journal of Clinical Microbiology and Infection in 2013. The authors were based in Israel, however the guidelines that they reviewed were from all around the world. The aim of the paper was to determine the methodological quality of guidelines on pneumonia and urinary tract infections. However, there wasn't an explicitly titled aim section in the paper, but it was commonly referred to throughout. How they went about this, they first conducted a literature search to identify the guidelines, and then each guideline was then appraised with the agreed to instrument. This was then done by 3 independent assessors, and then the mean aggregated scores were calculated and converted as a percentage score for each domain. In terms of the results, initially they had 42 potential guidelines that were found, but due to exclusion criteria of overlapping guidelines and non-English guidelines, this was narrowed down to 13 guidelines for pneumonia and 7 for UTIs. They were published between 2004 and 2013, and the 3 appraisers had a high Spearman's correlation with their agreed-to scores, suggesting similar findings and further validating the findings. This is table 1 from the paper, and it has the results of the agreed-to valuation for the pneumonia guidelines. And as you can see in the first left-hand column, the societies are from various nations: Sweden, Spain, Britain, America, South Africa, but also none from Australia. I've highlighted in the orange circles the extremely low scores, and then at the bottom in the red is a summary of the mean, standard deviation and medians for each domain. It's important to note that the agreed-to developers didn't define what constitutes a high and a low score. They leave this up to the appraisers. Generally anything less than 50% from what I've read in the literature is obviously not ideal. But the authors in this instance identified 4 poor performing domains of the guidelines, and this is stakeholder involvement, rigour of development, applicability, and editorial independence. Similarly, for table 2, this is the agreed-to scores for the UTI guidelines. And again, lower scores in orange, average, median and standard deviation in the red. And their 4 poor performing domains were again identified as stakeholder involvement, rigour of development, applicability, and editorial independence. On this slide here, I've just re-summarised the mean percentage data for each of the domains, and I'll elaborate a bit more as to why their scores or why they were considered as poor performing domains. For stakeholder involvement, scores were low across all 3 items, and the items in this domain addressed the membership of the guideline development group, whether the views and preferences of the target population were sought, so in that case it would be patients, and whether there was a clear definition of the target users of the guideline. Rigour of development I'll discuss on the next slide because it's quite a large domain. So then moving on to applicability, that refers to the likely barriers and facilitators to implementation, the strategies required to improve the uptake, and then the resource implications involved with actually applying the guideline. The authors of this paper specifically examined whether the guidelines addressed antibiotic stewardship programs and how to implement recommendations within such programs. And they both pneumonia and UTI guidelines scored very low, as this was not addressed well. Very few guidelines provided advice or tools for putting recommendations into practice, as well as any monitoring and auditing criteria. And then even fewer considered the resource implications for, again, applying these recommendations. Looking at editorial independence, the means are quite low. However, the range of scores was quite broad, from 0 to 94.4%. So some guidelines did this very well, and then others did not address it at all. So a high editorial independence would reflect appropriate processes and statements that ensure that when the guidelines were developed, there was no unduly biased, it was not unduly biased by any competing interests. So high-scoring guidelines reported any funding and then referred to it throughout the stages of guideline development. Where the authors stated where certain guidelines lost marks or their score was that they would declare conflicts of interest, but then they didn't actually explain how those conflicts of interest were then dealt with. So, yeah, there was lots of variety within that, but overall it was still a low-performing domain. Looking at the rigor of development, this is the largest domain with 8 items, and this looks at the processes used to synthesize the evidence and then the methods that are used to actually formulate these recommendations and then for future updates of these guidelines. Looking at items 7, 8 and 9, the search process was not commonly referred to, and the few guidelines that did had very restricted or poorly structured searches. The criteria for selecting the evidence and their appraisal was also poor, as no guidelines performed a risk of bias assessment of the individual studies. And any guidelines that did utilise a grading system, this was only limited as to appraisal of the classification of the study design, so level 1, level 2 studies, but nothing beyond that sort of appraisal. Looking at item 10, the method for formulating the recommendations also scored quite low, as most guidelines didn't discuss how consensus was reached. Guidelines that did score well in this area had a method applied, so methods such as the Delphi method or even just a simple voting process, just explaining how the formulations, the recommendations were actually formed, gave them a higher score. For items 11 and 12, the authors were surprised to find that there was a disassociation between the outcomes and the actual recommendations of the guidelines. So in particular, they found that there was no discussion of the ecological impacts of the antibiotic choice. And also for guidelines that did use these evidence grading scores, only half of them actually linked this back into their recommendations. Regards to item 13, only 7 of 20 guidelines reported external reviews, and for item 14, only 4 noted a plan for future updates. So you can see within this domain, it is quite extensive when it assesses the quality of the evidence, and that then guides the formulations of the recommendations. And from this, both guidelines for pneumonia and urinary tract infections perform quite low in this area. So after guideline appraisal, the authors identified some key issues regarding these infectious disease guidelines, with the main focus being on a lack of systematic methods used for evidence selection and then the development of the guideline recommendations. They proposed that guidelines should ideally start with defined interventions and outcomes. This then would provide a structured strategy for how the evidence is identified, appraised, and then linked back into the guidelines recommendations. So they found that this was not the case. An example of an intervention in this scenario would have been the use of an antibiotic in the treatment of pneumonia or a urinary tract infection. But because this wasn't clearly defined, a broader range of evidence was reviewed, but done so with no relevance relating back to the actual intervention because it wasn't stated. So we had a situation where we're appraising any evidence rather than evidence relevant to the actual guideline itself and the recommendations that they made. This was similar in terms of the outcomes. The authors found that there was a poor discussion of the relevance of the outcomes of the studies and then how they were linked back into the recommendations. An example that the authors gave was some guidelines addressed the coverage obtained from different antibiotics, but then neglected to address the clinical outcomes of that recommendation. So why we want that level of coverage and what they were going to achieve from doing that for the patient. The authors basically argue that this lack of a systematic approach to guideline development and this disassociation between evidence and recommendations can be a significant barrier to guidelines and their usability. The third point that I have there is epidemiological and ecological considerations. This was a unique ID aspect that the authors introduced to the agreed to appraisal. They found that there was inconsistent matching of antibiotic treatment recommendations to local bacterial distribution and antibiotic resistance data. Additionally, they said that ecological consideration of selecting one antibiotic over another in different epidemiological settings was also rarely discussed. Their authors are arguing that this area warrants further research because recommending broader spectrum antibiotics in areas with low baseline resistance could potentially further promote resistance rather than prevent it. In terms of limitations of the study, the authors, the guideline assessors weren't blinded to the source of the guidelines, creating a potential source of bias. Only English guidelines were included, so limiting the search strategy. And then the inclusion of this extra infectious diseases content to the agreed to instrument may have potentially lowered their scores because it was, in comparison to other literature, because it was extra criteria. However, the authors themselves didn't actually clearly explain how this additional content was incorporated into the agreed to. I've mentioned here a lack of acknowledgement of resources and data. So on the slide before, I mentioned the authors stated that there was this inconsistent matching of antibiotic treatment to the local bacterial distribution and antibiotic resistance data. But they didn't say where they got this data from, to what extent was this inconsistent matching occurring, and then what were then the consequences of that. So they mentioned it in the discussion, but didn't really elaborate the greater impact of it. Further limitations, not specifically to the study, but to our interpretation of the paper, is that there's no comparator studies for other infectious disease guidelines. So the agreed to tool has been utilised in other areas such as depression and osteoporosis, as I've mentioned, but nothing for us to compare to, say, for sepsis or surgical prophylaxis. And as well as I mentioned, no Australian guidelines were included in this review, so we don't know where our Australian guidelines for pneumonia and urinary tract infections then sit with other international guidelines. An inherent limitation for all guidelines is that the concept that a guideline is only as good as the evidence it presents. And then within the area of infectious diseases, this can be more so prevalent as there tends to be larger evidence gaps due to the minimal robust higher evidence and then the focus for the need of expert consensus. So this decrease in quality can then further impact upon guideline usability as well. So for conclusions of this paper, the authors found that the agreed to instrument was successful in identifying guideline components that required further improvement. And from this was the 4 domains of rigour of development, stakeholder involvement, applicability, and editorial independence. They advocated for systematic methods to be used when formulating guideline questions, outcomes, and recommendations. And this can then result in increased relevance, methodological quality, and applicability of the guidelines. And that for infectious disease guidelines specifically, we also need to consider local epidemiology and ecological impacts of these recommendations. As I've mentioned before, guideline quality will always be limited by the quality of its evidence base. So now going back to that initial quote that I've said about the need for high methodological standards, this interpretation of our evidence does require expert consensus review in the form of guidelines. But with these guidelines, they do need to be developed with these high methodological standards in place to promote their usability. Without this, there is a potential for guideline failure and subsequently the optimisation of clinical practice and therefore patient outcomes. What I'm trying to say is no guideline is perfect, but with so many guidelines being developed and there being a push for us to comply with them, it's important that we're able to critique them and be able to distinguish between what is a well-designed, high-quality guideline and one that is not. With this in mind, this then leads to an area of future research that I'm currently planning to undertake. So to date, the therapeutic guidelines, antibiotic surgical prophylaxis, has yet to have been appraised. Current NAPS data highlights that 40% of surgical antimicrobial prophylaxis use is non-concordant with the therapeutic guidelines. I anticipate that with appraisal of these guidelines with the agreed to instrument, we may be able to identify potential gaps in guideline usability and then provide further insight into factors that may be driving this current non-concordant antimicrobial use. From this data, such as the poor performing domains, we might be able to then inform future AMS interventions, policy or practice, with a focus on optimising surgical antimicrobial prophylaxis use and minimising the risk of antimicrobial resistance. I'll leave that to any questions. Does anyone have any questions? No? I'll look at the... Yes, Kaz?
So just in developing guidelines, for example, the National Consensus Guidelines for Neutropenic Fever and the antifungal guidelines. The antifungal guidelines are actually rated the highest ranking clinical guideline for fungal use in the world, actually. There's a publication that's very exciting. But the element of the consensus is actually really fundamentally important because you need that to contextualise it for the Australian healthcare environment because it is very different, and it's different because of access to particular drugs, the cost issues, the patient populations. So my opinion is that you can do a guideline out of a group of randomised controlled trials, but it's only a small part of what you need to do to get to a guideline that's actually implementable.
Yeah.
And I do agree that in Australia we should definitely be focusing on that last bit. You know, how is it that you implement the guideline and what is it that you do to measure it? And anyone who's gone in to look at the NICE guidelines actually have supplemental guidelines for evaluation, and they even go so far as supplemental guidelines for health economic evaluation if you're going to evaluate that guideline in your institution. So hopefully Australia is going to sort of build up that type of content, and it's unlikely that the therapeutic guidelines, for example, are going to be able to take on that volume of work, and I think this is one area where MCAS can really contribute.
Thank you.
So our next speaker, we're very excited to have our first remote dial-in. Yvette Bono is one of our associate investigators. She's a senior antimicrobial pharmacist for the Clinical Excellence Commission. So we're going to switch presenters to Yvette. So now we change presenter. Yep. Yep. And give it to Yvette.
Okay, good morning everyone. Can you hear me?
Yeah, we can hear you.
Okay, I'm not going to put the camera on for the moment, the webcam. I'll bring that up at the end. I just wanted to check before we got started. Rod, are we okay to go overtime with this, or do we need to finish by past?
Yeah, no, we'll go overtime. If anyone has to log out early, we'll send the recording to them all.
Okay, all right. Excellent. Okay, so good morning, everyone, and thank you to Jacqueline, Leslie, and Rod for helping me set up and present remotely. It's great to be able to do this. Are you seeing my little GoToWebinar screen, or just the slides?
Just the slides. It's all good from our end.
Okay, excellent. Okay, so the reason I chose this particular paper to review is looking at the guidance that's out there for antimicrobial stewardship teams. The CDC, in their core elements of an antimicrobial stewardship program, refer to antibiotic timeouts. And this is in their core elements of hospital antimicrobial stewardship programs guidance that was released in 2014. And when I read this, I thought, oh, this is something that I'm not too familiar with, the concept of an antibiotic timeout. And it is essentially asking the questions, does a patient have an infection that will respond to antibiotics? If so, is the patient on the right antibiotics dose and route of administration? Can we select a more targeted antibiotic to treat the infection, and how long should the patient receive the antibiotics? So even though it's not called a timeout, it's replicated in some other resources internationally. So in the UK, they have their Start Smart Then Focus package with this clinical review that happens at 48 hours. And in Australia, we have, of course, our antimicrobial stewardship clinical care standard. And two of the quality statements in that standard certainly advocate for a review once we have more information about the patient's infection, and also for patients that are on broad-spectrum antibiotics, guided by the patient's clinical condition and the results of microtests. So the paper I selected was this one, so it's called Taking an Antibiotic Timeout, Utilisation and Usability of a Self-Stewardship Timeout Program for the Renewal of Vancomycin and Piperacillin Tazobactam. And the things that I particularly liked were the self-stewardship part, the timeout concept, and the focus on the PIP-TAZ, because in New South Wales hospitals, this is one of our broad-spectrum antibiotics that we've seen increasing use of in the last couple of years. So in terms of the setting for this particular paper or study, it's a 200-bed tertiary care teaching hospital in the US. It's a hospital that's within the Veteran Affairs healthcare system, and it's a hospital that contains medical, surgical and intensive care beds. The primary methodology used for this is a pilot study, and it describes the development and implementation of an antibiotic timeout program to facilitate bedside or point of care decision making about antibiotics, and the authors collected data at 6 months after implementation. The antibiotic timeout in this paper is described as a review of antibiotic therapy on day 3 or 4 by the provider, and there's quite a lot of reference to the provider. So in the Australian context, we would say it was the prescriber or the medical team that's determining what medications the patients are on. All that review can occur by an antibiotic steward. So the concept here that the authors have emphasised is that a timeout allows for broad-spectrum antibiotics to be started during that initial period of clinical uncertainty when we might not know what the infection is, or we might not know exactly what we're treating in terms of the organism and its susceptibility. But it also encourages more specific treatment once the microbiology results are available or the clinical scenario is better defined. So they describe it as a bit of a balance between those two areas. So in the introduction of the paper, the authors talk about that antimicrobial stewardship requires a balance between restrictive and persuasive methods, and reference the Cochrane review that probably many of us are familiar with, that gives the evidence for both restrictive and persuasive methods. They propose that antibiotic timeouts provide one way to achieve the balance and preserve some prescriber autonomy, and that issue, of prescriber autonomy is something that's a constant theme throughout the paper. The project goal for this particular project was to allow prescribers to obtain automatic continuation, and they call that self-approval, of commonly prescribed broad-spectrum antibiotics by following a structured timeout process after 3 days. And the question is really, is this a self-sustaining antimicrobial stewardship intervention that could potentially be used in low-resource settings? So they selected 2 antibiotics, vancomycin and piperacillin tazobactam. And the aim of the paper, it's not clearly stated, but I think the aim is to describe the utilisation and usability of the timeout program, but I feel that the questions that they were trying to answer were, did providers opt to use the timeout template in lieu of ID approval, which was the usual process? If the timeout was used, did it lead to more inappropriate continuations of those 2 antibiotics that they selected? And how did prescribers feel about the components of the timeout program? Now, we know that checklists and timeouts are common patient safety tools. Most people are familiar with the surgical timeout, and that's very well known. But in the surgical timeout, it's really that final reconfirmation that everyone's on the same page. Do we have the correct patient? Do we have the correct procedure? And do we have the correct surgical site? Now, as you'll learn, that I think this timeout is a little bit different from just that built-in redundancy. So the methods that they used, so they chose the two of the most commonly prescribed broad-spectrum antibiotics to study. The pre-intervention process was that the ID team needed to give approval to continue these 2 antibiotics when they had been prescribed after 3 days. So the change was really that this process was waived if the timeout template was completed. And if it was, it gave the provider approval to use the antibiotic for another 2 to 4 days, and that the ID team still needed to approve further use beyond that 2 to 4 days. As a safety measure, they continued with doing the automatic infectious diseases team console for all Staph aureus bacteremias, so that process did not change. In terms of the intervention used for this particular initiative, the first one was development of an electronic antimicrobial dashboard, and I found this really interesting. So in the back they have a little screenshot of what the dashboard contains. So it contains some basic patient information, who the patient is and where they are. It contains their OBS, or their vital signs, as well as relevant lab results and the trends over 7 days by date. It contains information about what antibiotics the patient's been prescribed in the last 30 days. And it also contains microbiology data, so the cultures that were performed, what organism was identified, and what the susceptibilities were. So obviously this was only possible because they have a very extensive electronic health record, including electronic medication management, and they were able to pull this data into a dashboard or a report that contained the information that, that the project team felt was relevant for prescribers to make this decision about whether to continue either of those 2 antibiotics. Then they developed some timeout template, and so what happened is essentially the prescriber would select a pre-populated progress note in the electronic health record. If they chose to complete that, that was then reviewed by a clinical pharmacist, and the antibiotic order was renewed and the patient was able to get more of that antibiotic. So there is a logic in the paper that describes what questions they asked and how they stepped the prescriber through that process, but it was essentially about the presence of an active infection, culture data, and questions about the patient's current clinical status. If the timeout was not completed, the order was allowed to expire. So I think in our terms we would call that a soft stop on the order. So the pharmacist did a final review and then the order was ceased. The other interventions that they used was social marketing. So they engaged some influential clinical champions, physicians, to both formally and informally promote the program. And we all know from our QI projects that that's a huge component of successfully implementing an intervention like this. And they also supported the decision making with some educational documents. So in the paper there's a link to their guidelines, although that doesn't work for us, but it was just some guidelines placed on their intranet about the about that process of decision making and about what might be appropriate. In terms of what they looked at in terms of the effectiveness, that they measured some prescribing outcomes. So they did this through a retrospective electronic chart review for all eligible patients, looking at whether the antibiotic was continued, and if so, was it guideline concordant, and this is what they defined as appropriate or inappropriate, and did the duration continue beyond 5 days. And they also looked at episodes over 6 months from a period 1 year prior to implementation. If the timeout was completed, they looked at whether it was guideline concordant and did the duration continue beyond 5 days. And in terms of the statistical test, they used the Fisher's exact test and considered a two-sided p-value of less than 0.05 significant. And that test seems to be an appropriate one to use when your sample sizes are small and when you have two nominal variables. In terms of the usability study, they did user interviews assessing satisfaction to derive some questions. They developed a survey based on the system usability scale, which is a bit of an industry standard for usability. It generally consists of a 10-item questionnaire with 5 or 7 response options for respondents, from strongly agree to strongly disagree. And they use this because it was easy to administer, reliable and valid. But reading a little bit more about this, the scores are a bit difficult to interpret and need to be normalised. What they specifically looked at was satisfaction with the timeout template, the value of the dashboard, the template and the overall program. And to analyse the results, they used linear regression to predict variance and associations. There's not a huge mention of ethics approval, but they did say supervision and approval of the facility's institutional review board was obtained. It was funded with support from the CDC to the University of Utah, and there was no conflicts of interest to declare. So the results. So this is summarised in Table 1 in the paper, but I always like these visual things because they help me figure out what happened to people on the different courses of action. So for vancomycin, which was the first one that they tested the timeout for, there was 145 episodes. A huge 77 of those, the prescriber just allowed the order to expire. The timeout template was completed for 37.9%, so 55 of those orders. And the order was active for more than 24 hours with no timeout completed for 13 of those episodes, or 9%. When the timeout was completed, it was continued but ceased within 24 hours for 13 of those episodes, switched to oral for 3, and the largest group was that it was continued for more than 24 hours after that timeout was completed. For those, the ID team were consulted for 5, and then what the authors did was what the project team did was they reviewed those ones that were continued for more than 48 hours for appropriateness, and they found that 27 of those 34 were appropriate and 7 of those 34 were inappropriate or guideline discordant. Now this compares to their previous rate of 0, but that was when there was a more restrictive process in place. So remember, the previous way was if you wanted to use vancomycin for more than 3 days, you had to get infectious diseases team approval. When you look at the results for PIP-TAS, there are 105 episodes over that study period. About half were allowed to expire. The timeout was completed for the other half, and there was still an active order but no timeout process in 2 of those cases. So The ones that were continued but then ceased within 24 hours were 17 of the 52, 2 were switched to oral, and the majority, 33 of those 52 orders, were continued for more than 24 hours. A small portion got an ID consult, and so again the project team reviewed the rest for appropriateness and found that 21 of the 30 were appropriate and 9 of the 30 were inappropriate or guideline discordant. And this compares to their previous rate of 2 or 2% when they had more restrictive processes. So looking at those results in a different format, and this is table 2 in the paper, for vancomycin, the inappropriate continuations before the timeout were 0 and after the timeout were 7, or that should be 5%. The courses that were discontinued on day 3 to 5 before the timeout was 96 or 48%, and after the timeout was 64%. For PIP-TAS, it was a little bit different, so inappropriate continuations went from 2% to 9%, but that change wasn't considered to be statistically significant, and the courses discontinued went from 62% to 67%, but again, that wasn't considered to be significant. So when the authors summarised this, they concluded that when compared to a period prior to the timeout, when continuance was approved by the ID team, vancomycin timeouts showed overall higher rates of discontinuation, although guideline concordant continuations increased. In terms of results for the usability survey, so they had a response rate of 51%, or 32 out of 63 physicians who had used the timeout template. I found the ratings that were described in the paper difficult to interpret, so I would trust the authors on this one, and they said that there were modest ratings for attitude, usability and satisfaction, which I think means that the people weren't overly enthusiastic about the program. They did find an association between perceived usability of the dashboard in terms of intention to use the dashboard in future, but when they set out the beta value for that thing, it was fairly low, it was 0.12. And for the timeout template, satisfaction with the templates and general attitudes about the program strongly correlated with intentions to use the template in future. So the beta value for satisfaction was 0.95 and for general attitudes was 0.52. So in the discussion in the paper, they say that the intervention may have increased provider confidence in that decision to de-escalate in situations where they previously would have asked for ID advice to continue. So I found that this was interesting, that I think what the authors are saying is that the decision to de-escalate, to discontinue or to allow the order to expire was an intentional one, and maybe previously that decision was outsourced to the infectious diseases team, who may have limited information when they're asked to extend approval for a particular antibiotic. And the authors proposed that the clarity regarding when to continue was really straightforward for vancomycin indications, which may have led to the better results for vancomycin, and a bit ambiguous for PIP-TAS indications. And the example that they give is a hospital-acquired lower respiratory tract infection, where you may not get culture, you may not get your organism identified culture results and susceptibilities, and so there's a greater degree of uncertainty. So that may make the prescriber more keen to continue with the therapy. They expected to see some gaming of the system, but they found there wasn't much, and perhaps this was because the template became a permanent part of the electronic record. Really interesting in the paper, I think, was this the discussion on the culture of change and dual process theory of decision making. So I'm sure some of you are familiar with this, but this is that idea that we have two systems for decision making or thinking. System one, which is our fast, intuitive decisions, and there is a risk of bias or error when we make those decisions. And system two is our slow, more analytical, style of decision making, and this is resource intensive and requires more effort. So an example of that is if you had a rule for, say for example, patient presents to the hospital with pneumonia, your system one thinking might say, I'll just give ceftriaxone and azithromycin to all my patients because then I don't have to assess for severity, then I don't have to worry about, you know, what it actually is, and then when they go home I'll switch them to Augmentin. That would be a system one decision, whereas system two is let's think a bit more about what might be causing the pneumonia, what the severity is, and review the patient daily to see if we can de-escalate their therapy. So the authors propose that the antibiotic timeout process promotes deliberate system 2 thinking, but that this requires more cognitive effort. And so in terms of the usability and the satisfaction, they said anything like this is likely to be unpopular at the start, and that the motivation to use that template has to outweigh the cost for this to be an acceptable and appropriate intervention. Some of the limitations that are described in the paper were that they did not look at the appropriateness of antibiotic discontinuation, and I think this is a real limitation. So those decisions to either allow the order to expire or to discontinue therapy, how much of that was would have been considered appropriate. They proposed that potentially there were different types of patients over the study period, and certainly the patient types or what infections they had weren't matched or compared to one another, and that antibiotic prescribing decisions may not be made by the person completing the timeout template. And this is a typical situation we see where there's a junior doctor that's asked to go through antimicrobial stewardship processes in order to continue the therapy that the consultant or the lead clinician for that team would like. So they did point that out as a limitation. Also, the context of this intervention was at a hospital with a long-standing and robust antimicrobial stewardship program, and there was heavy reliance on the electronic health record to make this intervention work. So the limitation, I suppose, is would this work in a low-resource setting? My thoughts on the paper is that it's a really thorough report of this intervention and how it was implemented, and that it raises several questions for us in Australia. So how do we best use and synthesise information in the electronic health record to improve antibiotic prescribing? And lots of our hospitals are in different stages of having an electronic medical record, electronic medication management, or neither of those things. More self-stewardship process is desirable. So I thought it was interesting that these doctors had the option to do the timeout template and get that renewal for themselves, but some of them opted not to do that. And is it because of that extra effort? And if we try and implement more of these self-stewardship processes, we tend to think they'll be successful because the prescriber has more autonomy, but will they expend the effort for that system 2 thinking? And the other things were previously the ID team spent time on these extensions or continuations of proving the vancomycin and pip/TAZ orders. So what's the safety benefit of investing that time in that process versus the opportunity cost? What else could the AMS team be doing if they weren't approving those vanc and pip/TAZ orders? What we don't know is whether the intervention resulted in increased use of other broad-spectrum antibiotics, and they do say that they are planning to publish another paper that looked at the consumption, so that squeezing the balloon effect. I would have really liked to have seen a run chart of either the process or outcome measures for this particular project, so that we can see whether that variation is like just common cause variation or whether it's a special cause variation, whether we can attribute that and what the pattern was. Did we see that more of those discontinuations or more of those inappropriate orders in the early stages or in the later stages of the intervention? Was the intervention sustained, spread to other facilities, or reproducible? I think for this paper, further research is likely to impact our thinking on the benefit of a structured timeout process. And really, as I said at the start, I think a timeout for something like this is about decision making, whereas the timeout that we use in surgery is like, you know, a built-in safety redundancy. And I think it's great to see usability testing and cognitive biases and system 2 thinking brought up in an antimicrobial stewardship paper. So with that, I'll end and take any questions and comments, and I'll turn on my webcam if I can. Okay, that's me. Any questions or comments?
There's none on the webinar, but I think Kaz has a question.
Great talk a bit. I was struck by the kind of relatively, can you just go over the size of the hospital and the case mix? Because
yeah, so
I thought.
Yeah, so it was a 200-bed tertiary care teaching hospital, and they seem to have a mixture of medical, surgical and ICU patients, and they do refer to that with the implementation. They did the general medical wards first for vancomycin, then the medical ICU, and they did that just with vancomycin, did the same with the pip-taz, and then at the end they included the surgical ICU. There's not much more information about the case mix of the hospital apart from those three areas.
So it's probably a little bit smaller than many of our Australian tertiary metropolitan hospitals, I suppose. It's a bit smaller.
Yeah, and they did say that their infectious diseases team has a pharmacist, an infectious diseases pharmacist and an infectious diseases physician. And that every medical team in the hospital has a clinical pharmacist, because there is something about the stakeholders that this intervention impacted, and they said it would be the AMS team, the provider and their support team, and also the clinical pharmacists.
So it is, culturally it is actually really interesting, because Australia's had an acknowledged use of electronic approval systems, obviously, like guidance for years now, whereas not with sort of that concept of triaging and review. And that's something still relatively new in the US, so it's a very interesting study to see some of the comparisons with what we've been doing for a number of years already.
Yeah, definitely.
Thanks very much, Yvette, and I'm sorry that there was so much, such a delay at the start. We will let everyone know when the presentations are uploaded and link back onto the website, so anyone who had to leave early will send out. And I'll close off the Journal Club. Thanks, everyone.